Hi, welcome. Good afternoon. Thank you for joining us for today's webinar session, Ask the AMA Experts, Moving the Needle on Statin Therapy. We'll be getting started in just a few minutes. Thank you. Hello. Thank you for joining us today for the webinar on Asking the AMA Experts, Moving the Needle on Statin Therapy. We'll be getting started in just a couple minutes. Thank you. Good afternoon. Thank you for joining us for today's webinar, Ask the AMA Experts, Moving the Needle on Statin Therapy. We'll be getting started in just a couple minutes, so please enjoy our marketing slide deck where we have some key information on how you're able to participate in today's session, as well as other opportunities and how we're honoring American Heart Month. Thank you. Hello, good afternoon. Welcome to today's webinar, Ask the AMA Experts, Moving the Needle on Statin Therapy. We'll be getting started in just a few more minutes. Thank you. Good afternoon. Thank you for joining us for today's webinar, Ask the AMA Experts, Moving the Needle on Statin Therapy. We are about 1 minute after the top of the hour, so I'm going to go ahead and get this started by passing it to Dr. Tim Long, our Chief Clinical Officer for both Alliance Chicago and Health Choice Network.
Great, thank you, Stephanie. Appreciate that. And welcome to today's Health Choice Network Alliance Chicago webinar on Ask the AMA Experts, Moving the Needle on Statin Therapy. So let's look at the agenda first. And today, we'll walk through a few logistics. We definitely want to make sure that you understand the objectives for today's webinar. We'll look at some survey findings. Hopefully you filled out the survey in advance. And maybe a little bit of the Million Hearts Project overview. And then we're going to hear from our AMA partners and hopefully do an interactive question and answer session. So on the next slide, we have our webinar logistics. You have joined today's session in a listen-only mode, and so you are muted by default. But you can participate in the interactive question and answer part, even if you're calling from a telephone or your computer, but you want to make sure that you put in your PIN number. You can use the questions panel during the webinar to share any questions or answers or comments that you might have, and we'll in live real time be sharing those questions with everybody and hopefully engaging our partners at the AMA. This session will be recorded and you'll be able to revisit it after the session. So thank you again for participating. So for today, our objectives are we want to understand health center clinicians' experience on prescribing statin therapy to at-risk patients. We'd like to do a little bit of discussion on the Million Heart Statin Therapy Initiative for the prevention and treatment of cardiovascular disease. We might highlight some key takeaways from the 2018 Blood Cholesterol Guidelines through the interactive question and answer portion. And then definitely we want to talk about some tactics to address statin therapy clinical inertia. As you may be aware, we had asked many of you, or all of you actually, hopefully, to fill out a pre-webinar survey. And of those who responded, 50% are family practice clinicians. And of those respondents, 60% identified side effects as a top common barrier or concern for patients, followed by trying diet, lifestyle changes, and lifelong medication barriers and challenges. And so again, 50% of our respondents thought that the group of high cholesterol above 190 and the diabetic with an LDL between 70 and 189, 50% of the respondents felt that was the top at-risk patient population. And then 42% felt that the primary prevention category was the top at-risk patient population. So if we look at the next slide, we have our 2020-2021 Million Hearts Project overview. And right now, many of us are participating in the CDC-funded, NAC-administered Million Hearts program with two projects: statin therapy for the prevention and treatment of cardiovascular disease, where the purpose is to improve appropriate use of statin therapy for at-risk patients. We identify the population of focus as the three categories you see on the screen here. And we have national partners. There's 5 health center controlled networks working with us, 22 health centers, and of course, the CDC and our partners at the AMA. The second project, improving blood pressure control for African Americans, the purpose is to improve blood pressure control using evidence-based practices to intensify guideline therapy. And again, we're looking at a population of focus. We have the same partners, 5 health center controlled networks, 23 health centers, and of course, the CDC and the AMA. So with that, I am honored to turn it over to our guests, today's featured experts. And they will introduce themselves, but I want to turn it over to Dr. Kate Curley, who's going to walk us through the next portion of this presentation. So Kate, are you with us?
Hi, Tim. Thank you so much. I'm here.
Great.
Thanks for having Linda and myself. And by way of introduction, I'm Kate Curley. I'm a family physician. I'm Director of Chronic Disease Prevention at the American Medical Association. Have been working alongside many of you actually on the Million Hearts NAC administered project, and I'll let Linda introduce herself quickly too.
Hey everybody. So I'm Linda Murakami and I'm a registered nurse by profession. And I act as a senior program manager for practice facilitation and quality here at the AMA, and also working on this NAC grant for several years now with all of you. And I did have the pleasure of working with the Alliance some years back on the Evidence Now H3 project. So I don't know if anybody on that call is familiar with that, but we have a nice long relationship with you guys. So thank you for having us today. Talk to you. And I'll let Kate explain the rest.
I'll kick it off. So Linda and I have been working on the Statin project for a number of years now, and in our role, we serve as sort of clinical subject matter experts and do a lot of work on sort of the clinician training, clinician education pieces of this project. And we know that you all have had plenty of questions about statin usage, and so really grateful to have this opportunity to just talk through some of these questions. And so we thought we would keep it, on the informal side. And what we did was took a look at that provider survey that many of you completed and looked at some of sort of the questions that you have or scenarios that you gave as examples of situations where you're either struggling with statin management or just not quite sure what to do. And so we're just pulling apart some of those different scenarios and talking through, I think, some of the different considerations. So we'll spend, I don't know, the next probably 20, 30 minutes or so, I think, talking through. I think we came up with about somewhere between 8 and 10 different questions or scenarios. So we'll talk through that and reference the ACC/AHA cholesterol guideline a lot as we do so. And along the way, if we have any sort of links or lists or anything that might be helpful to you, we'll see if we can get those posted in the chat so you can reference those things as well. But we'll just be talking. And then along the way, if you're thinking of other questions, tough patient cases that you've come across, feel free to type that into the chat and we'll kind of try to do some more live Q&A after we work through these 8 or 10 sort of different questions and scenarios that we identified already from your survey. So I'm going to kick it off with our first sort of question or situation. And maybe first I'll just quickly recap just some of the basics from the cholesterol guideline that I think you're all probably really familiar with already. But if we wanted to boil the ACC/AHA cholesterol guideline down into just a few sentences, it really comes down to identifying whether or not patients fall into a specific statin management group, and then delivering and hopefully connecting those patients to the proper intensity statin therapy. And then the guideline also notes that lifestyle change and supporting patients in healthy lifestyles is absolutely foundational for all of our patients, especially the patients that fall into the 4 statin management groups, but that it's not sequential. So we're not recommending lifestyle change and then statin use. We're recommending both for all of the patients in these statin management groups. And Linda, I know in a minute we'll talk a little bit more about how lifestyle sort of fits into all of this. But by way of reminder about what the 4 statin management groups are, there's the adults with clinical ASCVD. So adults who have had, who have evidence of clinical ASCVD. That could include MI, stroke, TIA, peripheral arterial disease, ACS. So all of those things count as clinical ASCVD. They're our first group. They're probably our highest risk group, and this is really about secondary prevention in that group. And the guideline recommends we have those patients on high intensity statin therapy. The second group is the LDL greater than or equal to 190 milligrams over deciliter group. So this is actually, it's easier to say severe hypercholesterolemia. So severe hypercholesterolemia means LDL greater than or equal to 190. This is also a high risk group. And this, again, this is all adults who have this LDL level, and it's recommended that these folks all receive high intensity statin therapy. The third group are the adults between the ages of 40 and 75 who have diabetes and who don't have clinical ASCVD or the very elevated LDL. So they're our third group. And those are the three groups that I know the Million Hearts Project has focused on. Those are also the three groups where you don't need to perform an ASCVD 10-year risk calculation before you start treatment in those groups. They all are recommended to receive their statin treatment based off of those factors alone. So they're the three of our four statin management groups. And then that fourth group is what I kind of think of as that pure primary prevention group. So they don't have clinical ASCVD, they don't have severe hypercholesterolemia, they don't have diabetes, but they do have an elevated 10-year ASCVD risk. So they would have typically a 10-year ASCVD risk of 7.5 or higher. And that's the group, I think, where we start to run into more questions about sort of, what do I do here? Does my patient really fit into this group? And so one of the questions we saw, or scenarios we were seeing it come through in the survey, was what do I do with my patients who are sort of borderline risk and sort of may or may not fall into this sort of broader primary prevention category? So that's assuming that we've already determined they don't have clinical ASCVD, they don't have the very elevated LDL, they don't have diabetes. What do I do from there? So next step, I think, as you all know, is to calculate that 10-year ASCVD risk and see where they land based on that calculation. So if their risk is 7.5 to just under 20%, that is considered intermediate risk, and a moderate intensity statin is recommended. And then if their calculated 10-year risk is 20% or greater, that is considered high risk, and a high intensity statin is recommended. So that sounds pretty straightforward, but really there are other things to consider as well. And I know several of you have seen situations where you're sort of questioning the result of your sort of 10-year ASCVD risk calculation, and what do I do from there? So other things to consider are whether or not the patient has any risk enhancing factors. So the list of risk enhancing factors, and I'll send this to Stephanie so she can pop it into the chat so you have it, but the list of risk enhancing factors includes a family history of premature ASCVD, having an LDL level that falls between 160 and 189, so not as high as 190, but still pretty high. Having a persistent elevation of triglycerides greater than or equal to 175 milligrams per deciliter. Having metabolic syndrome, so lots of our patients there. Chronic kidney disease, chronic inflammatory conditions. For women, if they have a history of premature menopause or preeclampsia, people who fall into higher risk race or ethnicity categories. Those are sort of our main risk enhancing factors. And so if your patient has one or more risk enhancing factor, you are thinking about basically either initiating a statin if they're not already on a statin, or intensifying statin treatment in them. So it sort of almost bumps them up a risk level. And if they were a patient who had a borderline 10-year ASCVD risk calculation, so borderline means the calculation fell between 5 and 7.5%. So that group typically is not recommended to receive statin treatment according to the guideline. But if your patient has that borderline risk calculation plus risk enhancing factors, they are likely somebody who would benefit from moderate intensity statin treatment. So one way to sort of suss out these sort of borderline patients where you're not quite sure what to do is to think about whether or not they have any of these risk enhancing factors. One of the reasons that these are listed individually is because they're not included in the calculator. So none of these factors are actually taken into account when you do that risk calculation. So that's why you need to think about them a little bit separately. The other situation that can arise with some of those borderline folks is when you have somebody in front of you where you're getting this elevated risk calculation, but you're looking at them and you're thinking, I really think this overestimates your risk. I feel like you are, much healthier than this risk calculation is painting you to be. That is a situation where a coronary artery calcium score can be useful. So that's where a CAC can come in. So what a CAC score lets you do is potentially reclassify a patient when statin benefit is questionable. And essentially it lets you potentially reclassify that patient downward. So if you get a CAC score on a patient that is 0, that indicates a very low 10-year ASCVD risk. And that is a patient where you might be able to forego statin usage. You don't want to use a CAC score, or you don't want to get a CAC in people who are already on a statin. It's not helpful in smokers, not helpful for people with diabetes. As we noted, they're already in a statin treatment group. It is not helpful for people who have a really strong family history of ASCVD. As we noted, that's a significant risk enhancing factor, or people with chronic inflammatory conditions. So those risk enhancing factors really sort of supersede that CAC, or you don't want to get a CAC in those patients. It's going to be tough to interpret. But a CAC can potentially help you identify people who might be able to forego statin treatment. So I think with that, I will hand it over to Linda to take one of the questions that she thought about.
Right. So I'm going to go ahead and dive into the big one that everybody has concerns about frequently, and that's the side effects of statins, focusing particularly on the muscle pain complaints. So with the statin use, muscle aches and statin-associated muscle symptoms, they sometimes call them SAMS, S-A-M-S. They occurs in about 10% of the patients. So they're very subjective. They include like myalgia complaints, but if you did CK levels, you find most of them are actually within normal limits. And you need to always evaluate for the statin intolerance, but we need to exclude that other potential causes of the muscle related symptoms are there. So myalgia, if it's statin related, is usually it's bilateral. So patients with unilateral complaints of pain, we would have to further discuss and evaluate. There are patients who are truly unable to tolerate a statin, but it's very rare. You have to exclude the other potential causes and evaluate any recent activity the patient may have performed. Recently we had a whole lot of snow to shovel here, right? So was there new activity as in something strenuous like shoveling the snow that they maybe don't usually do, or they decided to take a really long walk that day, or did different things. We would have to evaluate for that. Diet and dietary supplements can also cause interactions with statins and cause other symptoms. So people who drink grapefruit juice could have issues with statins and some symptoms. Red yeast rice supplements users, there are apparently a lot of fans of that, and it comes up in the literature on a regular basis. They're at increased risk for the statin toxicity, which can lead to symptoms, because there's actually a compound called monosolin K that is actually identical to lovastatin. So if they're on a statin and taking that, it's going to increase their toxicity. And then if you determine there's no other cause and it may be really statin related, you could do the de-challenge, re-challenge with the statins. So you would stop the statin and look to see if for the symptoms to resolve, and that can take anywhere from 2 weeks up to 2 months. So once their symptoms go away, then you would re-challenge them. Ideally, you want to use the same intensity of statin and the dose. So sometimes it might make sense to try a different statin, but preferably you want to see if that same statin was really the cause. If the symptoms come back, then you would go ahead and try another statin, and knowing that not all statins are metabolized in the same manner. And because of that, changing to a different statin could actually be very helpful. And so you might also consider starting on a lower dose and titrating up. Some people have found that titrating up to the desired dose is a little easier on the system and may work to minimize or not have any of these symptoms, statin associated symptoms arise. And so just because your patients, keep in mind, just because they cannot tolerate one or more statins doesn't mean they can't tolerate all statins. So it's a bit of a trial and error. It may take a little time, but if the patient can't tolerate the desired intensity and you've tried many options, then you can, if it does work at the lower dose, you can use the lower dose. There's conversation out there. I don't know, the literature, how effective it is, but there is conversation about dosing, not every single day of the week, maybe every other day of the week, or just, on a set pattern of days and times. There's also the American College of Cardiologists website has a statin intolerance tool, and it kind of walks you through the process of entering, like the patient's age and sex, and then, any symptoms they might have. It helps you work through the process of, identifying that patient's potential, side effects. Is it really muscle related? And kind of some of what I talked through now, it would literally guide you step by step through. So we're going to get that website posted in the chat for you guys to look at and use as well. And Kate, I'll let you go to the next question.
Thanks, Linda. And actually, I've been asked that question a lot about dosing statins every other day for patients who are really struggling. And it was a question I didn't know the answer to. I went and did some digging around as well. Linda was also looking around for this. And what I was able to find is that, so yes, every other day statin dosing certainly can achieve LDL reductions that you potentially are looking for. You may need to consider a higher dose on that every other day basis to achieve sort of the similar desired reduction, or essentially the desired intensity of the statin. What really hasn't been studied, what I wasn't able to find much evidence for, is how every other day dosing actually impacts ASCVD risk reduction or reduces ASCVD events. So while there are studies out there looking at its ability to reduce LDL levels, which appears to be pretty good with dosing it every other day, I think it's a bit of an open question about whether it reduces events. So I think we push people towards trying to get towards that daily dose at the intensities that have been studied, but also recognize that everybody's a little bit different, and I think you just kind of work with your patients, and every other day dosing may be a valid option for those patients who are really struggling. So now to switch to a different topic that came up in a couple different ways in the questions that people submitted, was when to initiate a statin after a new diabetes diagnosis. A couple people noted that when patients are first diagnosed with diabetes, it's just sort of an onslaught of things that you're doing to them, adding new medications, starting sort of new monitoring that you need to do with them. It's a lot for patients to take. So do you really have to layer on the statin right at that time as well? And this is another tricky question where I don't think there's necessarily a super evidence-based answer. So certainly if you just sort of read the guideline as it is, once a patient is diagnosed with diabetes, a statin's recommended at that point. And for patients with diabetes, we want to use a moderate intensity statin. If they have multiple ASCVD risk factors, we're thinking about a high intensity statin in those folks. But I think it's also, very, very understandable to be concerned about overwhelming patients with a whole pile of new medications. And so it may be very reasonable to, for example, work on titrating anti-hyperglycemic meds first for a bit. But you don't want to drag out starting that statin for too long. You don't want to wait a year, let's say. Benefits of statins in people with diabetes are pretty clear. And you see reductions in all-cause mortality and vascular mortality that are measured on timelines like 4 years. So it's not as if our patients with diabetes don't see benefits from statins for 10 years or 15 years or 20 years. It's on a shorter timeline than that. So I think you don't want to necessarily drag out initiating that statin for too long, because patients do potentially benefit on a shorter timeline than sometimes we think. I think one important thing to note is that whenever you do start that statin on your patient, you do want to get that baseline lipid panel right before you start it. So, let's say that you had gotten a lipid panel at the same time you had diagnosed your patient with diabetes, but 3 or 4 months have passed, you've been getting them going on metformin or some other treatments, and kind of now you're feeling like it's a good time to add on that statin. you want to repeat that lipid panel right before you start that statin, because it could look different than it looked 4 months ago before you started treating that patient's diabetes. So you want to make sure you kind of get that current baseline before you do start treating them. But in general, I would say, I think you want to get people, new diabetics, going on their statins sooner rather than later. And I noticed a question come in on the chat that maybe I'll take right now too, that is sort of the flip side, asking about how can we address concerns about statin use and hyperglycemia. So multiple studies, some pretty large-scale meta-analyses have shown that statin use, particularly probably new statin use, is associated with a small increased risk of new onset diabetes. And so what should we do about that? Should we avoid statins in people who perhaps have pre-diabetes? If somebody does develop diabetes and we think it might be due to their statin use, should we stop it? The guideline's pretty clear on saying no, don't stop it, and no, don't avoid using a statin. So it appears that the benefits of statin use in people who are at risk of developing diabetes, or who even do develop new onset diabetes, potentially due to their statin, it appears that the benefits outweigh the risks. So the recommendations are to proceed with continuing to use that statin or initiating that statin. There are recommendations out there that also say, you want to keep an eye out for new onset diabetes. So obviously you can identify it and manage it as soon as possible. And of course, we also look back to that lifestyle recommendation component of the guideline, which is that we want to make sure we're supporting all of our patients with that foundational sort of lifestyle change support where we can. And our patients who are at elevated risk of developing type 2 diabetes, our patients with prediabetes, very, very important to support them with healthy lifestyle changes. Things like the diabetes prevention program that can help guide them through these lifestyle changes. Very, very important, but you don't want to forego statin use in those people. And I'll hand it back to Linda for another question.
Okay. You know what? I think I'm gonna go out of my order here and just bring it down to the lifestyle piece, because I know that one of the concerns people brought up was postponing the use of a statin and trialing lifestyle changes. So with Kate kind of bringing up lifestyle, I thought I'd just move right into that. And so, we know that, there's great benefits from the statins and the total cholesterol and triglycerides, but the statin drugs are really what are going to make the impact for us to be able to reduce, our LDL and triglycerides and increase levels of HDL. So the role of exercise and cardiovascular it's going to lower our cardiovascular risk, but it's less well established than the role of lipid lowering drugs. And the effects of diet are really modest at most. So for diet LDL reduction, like for example, using the DASH eating plan, has been able to show an LDL reduction of about 11 milligrams per deciliter on average. And then exercise, various forms of cardiovascular exercise, have been known to reduce the LDL-C by 3 to 9 milligrams per deciliter. So lifestyle really combined with the statin use is going to give us that effective decrease in LDL and triglycerides. But it's going to give us the cornerstone of treatment for lifestyle therapy for anybody with an elevated risk. And again, with all other cardiovascular health related illnesses, we want to really promote diet and lifestyle. But for this particular instance, we're looking to get 30 to 50% of reduction in LDLs, and we're just not going to see that impact on lifestyle and diet alone. So we really need to team that up with the statin to get the reduction in risk that we're really looking to desire. So it's really just, especially in these for high-risk statin groups that are mostly associated with the work that we're doing with NAC and the CDC. It's not probably gonna go work in our desire and to our benefit. So always, promote the lifestyle, but you really need to combine it with the statin therapy for it to be effective, especially for these high-risk patients with, high-risk ASCVD. So that's my comment for that. I don't know if you have anything to add, Kate.
Yep. It's not, no, I agree. It's not one and then, it's not start with lifestyle and go to statin. It's do both. It's do both from the get-go for sure. A question that I was taking was related to the ASCVD risk calculator and its imperfections and sort of how to deal with that. So, so to talk about that risk calculator for a minute, so it was developed using data from white people and African Americans. It tends to overestimate risk at the low end of the spectrum potentially. But that being said, it's still a pretty darn good risk calculator. So for certain racial and ethnic groups, it can overestimate risk. For certain racial and ethnic groups, it can underestimate risk. So it might overestimate risk a bit for people who identify as East Asian or Mexican. It may underestimate risk for people who identify as Native American or American Indian, South Asian, and Puerto Rican, for example. So it's not perfect. I think it's good to be aware that it can overestimate or underestimate risk a bit. It's also not perfect because of sort of what I was referencing earlier. So not all predictive variables that we know about are included in the risk calculator. So they built that risk calculator using data and variables where they had good structured data and could actually plug that into a calculator. But things like family history of ASCVD or some of those other conditions that we discussed, those types of data tend to not be available in structured ways, and so they couldn't be used to create the calculator. And so that's why the risk calculator alone is not intended to be sort of our only way to judge whether or not a patient benefits from statin. It's a really important tool. It gives you a pretty good prediction, but you do want to take into account some of those other factors. So whether or not your patient has some of those risk enhancing factors, whether or not they belong to a racial or ethnic group where the calculator could have either overestimated or underestimated a bit. And then, like I said earlier, for those patients where you think particularly the calculator is really overestimating their risk and you suspect their risk is actually lower than that, that is when you might want to consider the coronary artery calcium score to see if you can essentially sort of downgrade your patient's risk with that. So it's not perfect, but it does, it's a very helpful tool. And Linda, I'll pitch it back to you for another one.
All right, thanks. So somebody asked about shared decision-making and how to incorporate that with statin discussions with your patient. So we say that these shared decision-making should start to be used before we begin statin therapy and having the conversation with your patients. So, it's beneficial to patients by improving the patient care experience, and it improves adherence to the treatment recommendations if they actually participate in the care and coming to terms with, starting a medication, any medication or any part of a treatment regimen. So emphasize for statin specifically, you want to emphasize the benefits of the statin and the low risk of statin-associated side effects, including the muscle symptoms that we talked about, and give patients the information about the real risks and explain that if they experience a symptom, which is highly unlikely, that you can almost certainly address and fix it, and explain that it might take a little while to get to the drug that, they can tolerate and that offers them benefit. But make sure you give them a safe space to share their concerns, and know that we know that they're hearing a lot of conflicting information out there. Everybody's listening to every report on the weather. I'm sorry, on the news and things like that. So it's really trying not letting them get confused by their families and their friends and what they see in the media. And then encourage your patients, to talk about any symptoms that they're experiencing, and then, you're going to manage it together. And, because we're trying to prevent them from stopping medications without telling you. So make sure that they are not afraid to say, I don't feel good when I take this, and not be so afraid that if they experience symptoms, they think that it's going to cause some untoward effect, right away. So, trying to ease their fears. And then for the most part, focus your counseling on the benefits of the statins and the idea that, you'll be there again to address these issues when they arise. And we understand that part of the problem with this shared decision making, or even having these conversations about statins, is that they're lengthy, and we know that time is precious when you're trying to see your patients and get through all the appointments that you have in a day, along with all the other responsibilities that providers and clinics are dealing with. And we understand, especially now, this is difficult, but I think that if patients understand, it's a process that you're going to get through, but really being on the statin is going to be so much better for them, and how much it's going to improve, their cardiovascular health. The agency for Healthcare Research and Quality, ARC, they have some shared decision-making tools and resources on their website, and we'll get that posted to you as well, that give you help to have these conversations with your patients. So, Kate.
Thanks. So I was going to take a couple next that are almost mini cases that people presented to us, and I'll just kind of run through. I think I have 3 of them pretty quickly. So the first one was, what about pregnancy in women? What about a woman who's reproductive age and could become pregnant? So if you have women of reproductive age where a statin is indicated, this is where preconception planning is always really helpful whenever we can do it. So the recommendations about women of reproductive age are kind of as follows. So if you have a reproductive age woman who is on a statin and who is sexually active, they should be counseled to use a reliable form of contraception. We do, in general, want to try to avoid the situation where a woman is taking her statin when she's pregnant. Ideally, if a woman is planning pregnancy, you would want to stop her statin 1 to 2 months before she attempts pregnancy. And then if she does become pregnant while she is taking a statin, you want to go ahead and stop that right away. So this is all actually in the guideline. And so the general kind of recommendation is avoid overlapping statins in pregnancy when you can. This next case or example that came up was sort of, what about people under the age of 40 who have very elevated LDL or who have diabetes? So some of the younger age group considerations. So I guess I'll just say, first of all, that adults of any age with clinical ASCVD, or I should say up to 75, although really with clinical ASCVD, it's kind of adults of any age, and adults of any age with severe hyperlipidemia, so that LDL greater than or 1 equal to 90 group, they should all be treated with statins. So if they're 25 and they fall into that group, the statin recommendation applies to them. For adults who fall in the age range of 20 to 39 who have diabetes, what to do with them is sometimes a question, and sort of it comes down to sort of that risk picture overall. So if they've had long-standing diabetes, so that means 10 years for people with type 2 diabetes, it means 20 years for people with type 1 diabetes. So if they've had long-standing diabetes, it's probably reasonable to use a moderate intensity statin. Or if they have other major CVD risk factors, or if they already have evidence of microvascular disease, so they already have retinopathy, they already have nephropathy or any other evidence of microvascular disease, if they're between the age of 20 and 39, it is probably reasonable to start them on a moderate intensity statin. But then for adults who are 20 to 39 who don't fall into one of those groups that we just talked about, the clinical ASCVD, the severe hyperlipidemia, or the diabetes, sort of long-standing or complicated diabetes. If patients don't fall into one of those risk groups, there really isn't good evidence to recommend statin use just for sort of that pure primary prevention. So that's kind of where the recommendations fall with that younger adult age group. And then I got a couple questions as well and sort of scenarios related to triglycerides. So one example that I think somebody put into the survey was a 63-year-old female with triglyceride levels of 588 and kind of struggling with side effects from a variety of different statins. So what should I do with somebody like that? So triglycerides, how to tackle those. We could have probably a whole other lecture talk about that. When you see those really elevated triglycerides, really persistently elevated triglycerides above 175, certainly once you start getting above 500, one of the first things you want to do is really start looking for secondary causes. So in this example, I think that somebody gave me a patient might have diabetes. Other potential secondary causes would be chronic kidney disease, chronic liver disease, hypothyroidism. I think the highest triglyceride levels I ever saw in one of my patients was somebody who ended up having hypothyroidism. Other medications, so for example, thiazide diuretics can raise triglyceride levels. So you want to look for secondary causes or things that could be contributing to their hypertriglyceridemia and attempting to reverse whatever you can. Lifestyle with triglycerides is an extremely important underpinning as well as it is with the rest of cholesterol management. But then what to kind of do from there. So if you have somebody with a persistent severe hypertriglyceridemia of 500 or greater, and they have an elevated ASCVD risk of 7.5% or higher, the recommendations are to use a statin. So either initiate a statin or intensify a statin if they're already on it. And then if you still have persistently elevated triglycerides, we're saying above 500 on that statin, that kind of maxed out statin, then you're looking at things like implementing a very low fat diet, telling your patients to really, really avoid refined carbohydrates, avoid alcohol. You may consider adding in omega-3 fatty acids at that point. And if you have a patient where you're actually, the levels are so high, 1,000 or greater, especially where you're concerned about pancreatitis, that's when you would consider adding a fibrate. The point of the fibrate really is just to avoid the pancreatitis at this point. And they recommend generally the fenofibrate over gemfibrozil. So again, fibrates really kind of just to avoid pancreatitis. So that's kind of rapid hypertriglyceridemia in a nutshell. But when you see those really high triglyceride levels, I think that's when you really want to be thinking about secondary causes and looking for those situations where you can potentially reverse that. Linda, did you have any other questions or scenarios that came up?
I have one more question for me to cover.
Go for it.
The burden of adding medications. So people brought up, patients are already on so many meds, and so why, how am I supposed to talk about adding another medication to the regimen? And we all know that, polypharmacy dilemma has been an ongoing problem since, for years. So it's complicated for those who need to be on a statin, and they're also on these other meds for all these chronic diseases. But each patient's going to have a different perception on what is too many pills, right? So, always have the conversation with the patient about the need to add an additional medication, for the purposes, of statin and the LDL. Again, going back to the shared decision making sure they completely understand the purpose and the intent of the medication, what it's going to do for them in the long run, in the short term. Very important for them to understand. And so you want to have, again, these open conversations with the patient, talk to them, use infographics. There is a an infographic that NAC put together that Kate and I participated in that talks about like the effects of the statin as opposed to, you know, just diet and lifestyle, right? So, you know, that might give them that visual impact that to show, you know, this is worth it. I'm not concerned about adding another pill because it's going to do so well for me, you know. So we'll get that link and add that into the chat for you as well. And then, you know, we know that patients all, you know, hesitate to take statins, you know, again, for those reasons that they've heard from their friends and neighbors and, you know, their sisters or somebody, you know, complaining about side effects. You know, again, it's stressing that everybody reacts to meds in different ways and that most people don't have any reactions to the meds. And then on a regular basis or just sort of ongoing, and, you know, not just talking about statins, but we're talking about the patient's, you know, medication profile in general. Just, you know, regularly, especially when you anticipate the need to add meds, you know, look at your patient's medications list, look for, you know, meds that, you know, reassess each med for the need to keep, you know, using it, keep that prescription active. Look for options of single pill combinations when they're available. Use once a daily dosing when it's available. And then if you use statins that have longer half-lives, like atorvastatin, rosuvastatin, fluvastatin XL, it allows each patient to take the medication at a more convenient time of the day. So if, you know, we say you're supposed to take the statin, you know, in the evening or at bedtime, you know, maybe they're taking all their other medications, you know, earlier in the day and they don't want, they'll forget it because that's the one thing they have to take at bed. Then those drugs are okay to take, you know, earlier in the day. You can take them at any time. So whenever's convenient for them, you can take advantage of that. So, so that's all I had to say on the burden on medication.
Awesome.
Okay.
And I'm seeing some questions coming in through the chat, and we can start to take some of those. And I also thought maybe I'd comment a little bit on the severe hypercholesterolemia group as well, because I know with the survey, you all noted that that sort of LDL greater than or equal to 190 group is a group that you probably have on statins more infrequently. And I think that we've heard that a lot throughout this Million Hearts project, that LDL greater than or equal to 190 group is kind of a unique group where I think it's probably a mixture of things. I think some of us as providers don't always feel as comfortable with that group. They sort of feel like a carve out. And oftentimes they are a younger group. And so they don't always look like sort of the typical picture, elevated risk picture that we're used to seeing with many of our other patients who, you know, have a lot of other CVD risk factors. Sometimes our LDL greater than 190 group, you know, looks like the picture of health otherwise, and then they just have this very elevated LDL level, and it makes them feel different in some way. So I think things to know about that group are they truly do have a dramatically elevated risk. A large number of these patients who have LDL greater than or equal to 190 also would qualify for a diagnosis of familial hypercholesterolemia. Familial hypercholesterolemia is sort of the genetic diagnosis, we could say, and severe hypercholesterolemia is basically the phenotype, so the result of that. And really what sort of it comes down to is you treat the phenotype. So regardless of whether patients have genetic abnormalities, and you can certainly get genetic testing is generally recommended to help sort of clarify whether or not this is something that you need to look for in other family members, but genetic testing alone doesn't determine whether or not patients get treated. It's that LDL level that really determines whether or not patients should be treated. So you can proceed with treating them without getting a genetic workup, but consider a genetic workup if you have access to it. The other thing we see with that LDL greater than or equal to 190 group is people really want to go looking for other causes of what is driving that LDL level up so much. And in young people, in people who also have a really elevated really elevated triglyceride level, it is reasonable to go looking for secondary causes. You can just do really basic sort of evaluation with kidney function, liver function, TSH. but you don't necessarily have to go seeking a lot of secondary causes, because the reality is that a true secondary cause of a lipid level like that actually is relatively infrequent, and oftentimes it's real. It is what it is. You also want to think about whether there are other medications the patient is on that could be driving that lipid level up that high, and if it's possible to modify them, then you can do so. But again, I think with that LDL greater than 190 group, just I think recognizing that even though they might not look like that high-risk patient we're used to seeing, they are quite high risk. They clearly benefit from treatment, and we should, generally speaking, be using high-intensity statins in those patients. They're sort of a unique group. And then to take a couple of the questions that came in to the chat, I think we have just a few more minutes to do that. I saw the first question about, can we get non-fasting lipids for screening? Yep, definitely. You can go, you don't have to have patients fasting for their screening lipid panel. Situations where you would want a patient to fast would be if that panel ended up coming back with a significantly elevated triglyceride level. The trigs are really the ones that are most influenced by fasting. So if you do get a crazy triglyceride level, then you do want them to fast and repeat it. The other group of people where it's recommended to get a fasting panel are people who have that significant family history of early ASCVD or familial hypercholesterolemia. You do want a fasting panel in those folks. But otherwise, all the recommendations are saying you can get a non-fasting panel. And then I think we addressed some of the other questions already about every other day dosing and some of those concerns about statin use and hyperglycemia. I think I saw a question pop up about how do I handle a patient with prediabetes and the calculator. So the calculator really was developed to be sort of cut and dry. So when the calculator asks you, does the patient have a diagnosis of diabetes, it actually means diabetes and not pre-diabetes. So you would sort of plug it into the calculator and say, no, they don't have diabetes because they have pre-diabetes. But, we also all recognize that abnormal glucose is really, a spectrum. All of this is kind of continuous and not categorical. So, whether you consider prediabetes to be a risk enhancing factor, metabolic syndrome certainly is a risk enhancing factor. Prediabetes is shown to be associated with elevated ASCVD risk. So I would lean towards being a little bit more aggressive with statin use in people with prediabetes, but also kind of recognizing the conversation we had earlier about lifestyle change being, absolutely crucial for this group. The fact that in people who are at risk of developing diabetes, you do need to keep an eye out for whether they might actually develop diabetes if you do initiate a statin in them. But these folks are generally going to benefit from statin use. Linda, I don't know if you noticed any other questions in the chat that we didn't catch yet.
There's a question at the end that I'm kind of reading, but I think we'll have to investigate. It says, how viable is the 3D printed medications from the different time release tablets made from soluble polymers for their type of patients?
I don't know.
Maybe this type of
Interesting
patients.
question. I don't. Right. That's one you stumped me. I definitely don't have an answer.
So we'll have to.
It's a good question.
See if we can come up with an answer. Be afterwards, and we'll forward it on to everyone to get it. If we find an answer.
If we do find an answer,
that'll be the key. Yeah. So
hopefully we covered most of your questions, and I think we can always find a way to follow up afterwards if folks do have more questions. And I think with that, I can hand it back. I think back to you, Tim.
Great, thank you, Kate. And once again, I want to thank both you and Linda for all the time and effort that you put into this. I know this is not, easy to do all the time, but we really, really appreciate it. And the clinicians within our networks of both Alliance Chicago and Health Choice Network really appreciate our partnership with the AMA, specifically with you and Linda. So once again, thank you very much. Our staff really enjoyed the format of this, of having this kind of survey out ahead of time and garnering some interest. And there's all kinds of chatter behind us trying to maybe do a virtual roundtable or something in the future, because I think this format was really great and informal and really nice. So once again, on behalf of Health Choice Network and Alliance Chicago, thank you, Dr. Curley and Linda and the AMA, and we appreciate it.
It was our pleasure. Thank you.
Great. So everybody, have a great day. This session was recorded. We will be sending out the link, and we appreciate all of the time that people spend on Alliance Chicago and Health Choice Network webinars. And if you ever have any ideas for future webinars, please let us know. You can email or text any of us, and we will get on it. So on behalf of our teams, thank you and have a great day.